Joining us on stage is MacArthur Foundation Fellow and founder of Community Solutions, Rosanne Haggerty.
This is Ed Givens, and I first met Ed in 2008 when he was living on the streets of Skid Row in Los Angeles. And my colleagues and I had been working on homelessness for about 20 years at the point we met Ed, and Ed had been homeless on the street for 17 years. Now, homelessness is a major health issue. Chronic homelessness reduces life expectancy by as much as 25 years, and homeless individuals are disproportionately high users of the healthcare system because that's where the human and the financial consequences of homelessness tend to show up. And they show up there first, and they show up there most persistently. Now, for most of the time, most of those 20 years that my colleagues and I had worked on homelessness, we thought of design as what we drew on to create new housing options that integrated formerly homeless people into mainstream affordable housing and integrated health and mental health services into that housing for those who needed that support. We built buildings like this former hotel in Times Square that proved that the supportive housing, as the term came to evolve, that combined all of these different populations and different supports was a lasting and cost-effective solution to homelessness for those who lived there. But something was off. We had built thousands of units like this, but a decade after many of our buildings were open, we were still walking past individuals in situations like Ed's who were living on the street. And we realized gradually that there was no apparent relationship between the housing we were building and what was happening to people like Ed, who remained in the most extreme distress. And so we began looking at why people on the street weren't getting into the housing like ours that was being built for homeless individuals, and why more and more money was being spent on homelessness, and homelessness was increasing. And so we started meeting with individuals living on the street to ask about their lives and what they thought they needed to solve their housing problems. We then gathered groups of organizations that had resources that could provide housing: the mayor's office, the housing authority, the VA, health and mental health services, not-for-profits, landlords. And we asked them to start mapping the system for moving someone experiencing homelessness from the street into a stable home, following all the rules and processes that these different organizations had created. Well, in one of those efforts, this was in Long Beach in California, LA area, those who participated in the exercise discovered together through this design exercise the inadvertent role that each of their organizations was playing in increasing and perpetuating homelessness. If you count them, there are about 87 steps there, and it's actually impossible to complete. What this revealed was the array of bureaucratic behaviors, rules, and processes that had sort of innocently evolved in each of these organizations that guaranteed that the most vulnerable people could never escape homelessness. So almost by accident, we discovered the power of using design to see the problem we'd been working on for years in a new way. And even more powerfully, we saw how design thinking could enable a group of disparate actors to come to a fresh view of homelessness and see a new direction. And so what if what this all surfaced in this new direction, that the people who had this experience in many cities where we brought this whole process to, what they saw was the need to go to the user, to individuals like Ed, and ask them about their experience of getting from the street to a home, and to begin redesigning the behavior of the organizations to enable that to happen. And what we learned from Ed, and frankly everyone we ever spoke to on the street, was what that individual wanted was a safe, stable place to live. And what they would also need would be a coherent process for helping them get to that point, and where needed, to connect to the health and mental health supports that would allow them to stay in housing and to begin to build a more stable life. And through this process, and I'll just highlight LA, that group and the Long Beach group began working as a team. They put aside arbitrary rules and processes that had lost their meaning. And in Ed's case, Within a few months, they had found him an efficiency apartment in a building just a few blocks away from where he had spent 17 years on the street. And what ended Ed's homelessness and the spiraling health problems he was experiencing, therefore, was not just an affordable apartment, because the apartment had been there all along. It was actually in view of the corner where Ed had spent those 17 years. What was needed was a well-designed system. And here's what the LA coordinated entry system for housing looks like now. So from that to that. And here's what Ed looks like now after being in housing. And so one way to measure a better system design actually is to multiply Ed's stories many times. How about 100,000 times? Because we then launched a movement to start teaching this design process to cities around the country. And we launched the 100,000 Homes campaign in 2010. And it's essentially, the notion that we have many of the resources, not all, but many of the resources we need, but they're not organized well, and they're not organized around the user. And so the goal was, within 4 years, to house 100,000 of the most chronic and medically frail people, homeless people living on the streets of our country. 186 communities signed up, and together they housed more than 105,000 individuals by the deadline. And with the exception of critical new rent subsidies for homeless veterans, communities accomplished this using mainly the resources they already had, but learned to design the relationship between the resources and the organizations and the user in revolutionary ways, to organize them around the most vulnerable system users. Now, an independent analysis of the implications of all of those vulnerable homeless people who are high users of the healthcare system being housed was that collectively that represented $1.3 billion in annual recurring cost avoidance savings to taxpayers. We also had an Urban Institute study done that showed that communities who participated in the campaign had a statistically significant reduction in homelessness over communities that did not, and that participating communities improved their own housing placement rates on average 262%. So now we're working with local teams in 70 communities to do something that's even more ambitious, to get to a sustainable zero on chronic and veteran homelessness. Because what we found in the 100,000 Homes campaign is that communities could actually mobilize to do a sprint around kind of employing different design techniques, but it was going to take something else to actually embed those new behaviors and practices. And so the 70 communities who represent large cities, counties, and even entire states are working around a whole new set of design-driven metrics around how you actually know at any given time by name who's homeless in the community, their level of need, who is in the most vulnerable health, who needs to be prioritized for housing, how many individuals are actively homeless, and your housing placement rate. And so actually, I think what we've learned and continue to learn is that ending chronic and veteran homelessness looks a lot like ending a polio epidemic. It's a problem you have to solve every day, that it's about a rigorous use of data and person-specific attention. And there are fewer people homeless in the country as a result of this. It's not happening everywhere, but what we see a line of sight to is that these tools of bringing data analytics, design thinking, and quality improvement together represent a way we can tackle complex social problems like homelessness in very powerful new ways. So let me pause on the data question for a minute, because in addition to design thinking, I think this represents a very important leap in terms of the use of data in the delivery of social supports. It's not data used for judgment, it's data used for learning, data used to drive collaboration and ongoing system-level improvement. And a common dashboard like this, we find, keeps all the players in a community at the table and focused on community-level targets, and pulls the participants out of the mindset of thinking in terms of their own agency or just a single set of questions, and really thinking in terms of the whole. And so in the 2 years since we launched Built for Zero, here are the results. It's pretty powerful, and I'll say that the communities who've ended veteran and chronic homelessness, we've arrived at something called functional zero to represent the fact that this is a problem you have to solve every day. You need to know by name in real time who's homeless and have a housing system in your community that can always stay ahead of what will probably always be a threat for vulnerable people, the loss of their home. And the goal is to make those experiences rare and short. And already, based on the community's reports, we're seeing estimated taxpayer savings that are pretty significant. But the bigger issue that we've come to see is that homelessness is actually a symptom of a larger problem. And that is that many of the support systems that vulnerable people rely on to stay healthy are failing and must be redesigned. And we've concluded, based on data, based on our conversations with many homeless individuals and families now, that the key places to begin this redesign around health are in the neighborhoods of the country where the conditions for supporting health are the weakest and the worst. And let me focus on this work now that we're doing in Hartford, Connecticut, to get upstream of the problem of homelessness. And here's a map of Hartford seen through the lens of public health. Now, Hartford itself is a poor city with very low health rankings, but even within Hartford, you see, there are places where the health outcomes are the worst. And we find that in the blue dot area, that's the northeast neighborhood, that these are the same neighborhoods, not just here, but where we've looked throughout the country, that you have highest rates of eviction, unstable housing, institutional involvement, children in foster care, as well as very high rates of avoidable health crises. And so in organizing now over 30 local organizations, local government, larger institutions, and residents to take on the question of creating a healthier neighborhood here, one of the projects that we began with was looking at the neighborhood residents who are the most frequent users of the local emergency room. One of them was Shakoya, who, when we met her, had been at the emergency room 25 times in the previous 9 months with poorly managed stomach pain. And our community care coordinator worked with Shakoya and 11 others of the most frequent emergency room users from the neighborhood. And for that 9-month period, we looked at what it would take to devise a better system, to do a workaround, and to get to a point where everyone was reporting better well-being, and we saw measurable health improvements. Here's what, when taking all 12, we saw were the average experiences in terms of weeks and months of waiting in different places in the system. And if you were to total this up, you'd find that only about 20%, 23% maybe, of those activities had anything to do with healthcare, most with benefits, housing, transportation. And here's what it actually took to turn around Shakoya's situation and to reduce her dependence on the emergency room. It was basically finding out from Shakoya what she needed, getting the hospital, the primary care clinics, the job centers, and Shakoya's mother all to be part of the team. Her ER usage dropped. She's now in a full-time job, and she's now in night school, actually. And she's living in decent housing. And what's striking is that all of these resources existed before we showed up, but they had to be connected, and they had to actually be aligned around what Shakoya needed. And so we're now using the results of this kind of early work to inform a much larger neighborhood health initiative that we're calling the Northeast Hartford Triple Aim Collaborative. This is important news. We also tracked the impact of all of those 12 individuals and what it meant in terms of the impact on the healthcare system. Pretty profound reduction in emergency room costs and visits. But we're applying this to a whole neighborhood now. And we have, with our homelessness team that works nationally, developed an agile problem-solving curriculum to embed design thinking in the work that residents, local institutions, the city, Yukon, a whole group of us are working to turn around health outcomes in the neighborhood. And agile problem solving brings into alignment and makes accessible for a whole range of people. Design thinking, data analytics, quality improvement, and we're still learning what are other methodologies that are complementary and can help the users and the system around them actually work collectively toward improved health. And this is what we're aiming for as far as a measurable change in Northeast, and we hope this can be a template for other neighborhoods who are similarly distressed. A framework we're calling the triple aim, because success must be about more than improved population health or improved well-being or improved value of public and private investments in supporting health and well-being. It really must be about all three. And so this design process involves teams working on the built environment, teams working on food systems, teams working on public safety, and teams working on community care management for individuals in the community with the highest rates of chronic illness and with the worst housing conditions. And so I'll end there with just a real endorsement of the idea that design and ideas around design thinking put in the hands of users can really be a powerful lever for change in population health, well-being, and in the outcomes that we want for all of our fellow citizens. Thank you.